manage it in the labor ward. My slides are visible, I hope?
Yes, but we are not on full screen. You can put on full.
No, a minute, allow me to juggle with technology. Something not right there.
Doc, just go to slideshow.
Oh, it's disappeared, dear. Okay. That's better?
Yes, well done.
We are okay
together
now.
Thank you so much.
Yes,
Thank you so much for your patience.
Thank
so as I was saying, I want us to share a bit about our experiences and what we expect as we live in this new COVID era. I don't think I need to introduce so much about what COVID-19 is all about. This is purely a disease that is caused by a virus, a group of virus that is called new novel virus, corona, that belongs to the old number of old viruses that we've always known called coronaviruses. One of them being the common influenza flu that we all have suffered from at one point, spanning all the way to some severer forms that include SARS and MERS that have been reported in the West, in the Far East previously. It's an RNA virus, and it has it basically gets into the human system through the epithelium of the respiratory tract, likes the cuboidal cells, and it goes all the way to attach to particular pneumocytes, particularly the AC angiotensin converting enzyme 2 receptors, and that is where the virus mainly attaches. As you can see the structure, it has all these proteins that allow it to attach to those particular receptors. And then, as I said, it's an RNA virus, so it cannot live on its own. It has to incorporate in the host cell system for it to grow. And then, of all the people that have been said that it's commonly affects the elderly people above the 65 ages and people with underlying medical conditions. You can see pregnancy has not been mentioned as one of the conditions that predisposes to getting coronavirus infections. And what is known that the pathology it forms, it's basically from the production of a lot of immunologic reaction. The body gets an immunologic overdrive and produces a lot of cytokines and other chemicals that affect not just the respiratory system, but go further to affect other systems, and the patient's condition deteriorates. And I'm sure we are aware that it's not everybody who has coronavirus that gets to really suffer very severe morbid conditions. There are a number of people really get it, and it's really a mild form, and they're asymptomatic. So we've had this condition for not longer than, the reported case from China from December, that is at least 6 or 7 months when the first case was described. And then in Kenya, we got our first case in March. And I'm sure we all know the world's numbers have really risen. We have about 8 million people already infected, and nearly 500,000 people have died from coronavirus. In Kenya, as you've been watching, the cases have started now rising quite rapidly. We have more than 4,000 cases. We've had about 110 plus deaths. That table there, the graph there shows, I don't know how clear it is on your screens, but you can see the tip here is Africa, and the disease is slowly getting into Africa, after having done a lot of damage in the Americas and slightly the Eastern Mediterranean parts of the Middle East. It's not so much, but and I'm sure you are aware of the impact it has had in Europe. So we are seeing a decrease in the cases with time. Southeast Asia, also their numbers are still high. Western Pacific, Australia, New Zealand, very low cases. And these are variation that we are noticing in the epidemiological patterns, and a number of theories are being floated across as to why this is the case. But I think it's just a matter of time for us to know. As I said, the disease as it came, we just knew there was a respiratory system disease that affects the respiratory system and gives you pneumonia, just like the other SARS and H1N1 were doing. But this has surprised everybody because it goes beyond just the respiratory system. In the respiratory system, it causes very severe respiratory syndromes, but it is a multi-system disorder that has been found to affect the cardiac system, giving lots of myocardial infarctions and the like. The genital system, the gastrointestinal system, very severe hematological conditions have been reported, including coagulopathies and the like. And beyond that, a lot of mental and psychological problems have been reported related to the COVID pandemic. And coming to where we are today, the reproductive health system may not be spared fully. And I want us to look at the reproductive health system not just as a physiological system and the disease that it impacts it, but in the reproductive system or the reproductive health scenario, the arena of the reproductive health, we have a very severe indirect impact of the COVID. The indirect impact of COVID is enormous. Number two, we also have direct effects following the COVID disease. So in terms of the indirect effects, I'm sure there are now words that are common in the communication that has changed. Nowadays, we're talking about lockdowns, curfews, isolation, quarantine, and all those things, school closures, and all these things have resulted in one way or another. They have an impact directly to reproductive health, access, and other things. We have confinements, we have people not able to get to maternity units. Nairobi, as one of the biggest maternity units, is in Pumwani. Just the other day, there was a curfew in Pumwani, so mothers could not access the facility, the services. We have people fearing to come to the hospital for fear of contracting the disease. We are aware of the issues of Mbagathi. Once it became an isolation center for COVID positive patients, the mothers in Kibera don't go there anymore for maternity, or even if they go, there are very few of them. There are financial constraints. People have been hit by this COVID thing. So even the purchasing power is a problem. And this has a direct impact on the quality of healthcare, particularly reproductive healthcare that we want to give our mothers. The supply of commodities, the staff, their numbers are low, their morale is low, they have fear, they have stigma, and all those kind of things. So really, besides being a disease, the social and the other impacts that it has are a lot. I'm sure you've seen these newspaper cuttings. These are assorted newspaper cuttings telling us various issues that are arising from the COVID pandemic. Of course, high on the list is what is trending currently, about 3,000 plus young girls, either college or primary school or secondary school girls, who have been impregnated over this short duration. And this scenario replicates not just from much, it's also in other counties. And it just tells you there is a problem with COVID that we need to address. Adolescent fertility, issues of HIV taking a backseat now with COVID, child abuse, sexual violence is a lot. Patients visit to hospitals dwindled. Private hospitals are struggling to stay afloat. And all these things here have a direct impact to the outcomes that you intend to have. Unintended pregnancies or unplanned pregnancies are going to increase. And we know there are elective surgeries that were postponed. And so we really need to look at that indirect impact of COVID to all of us. As I said earlier, we don't have a lot in terms of the direct impact. The countries that have experienced COVID over a longer time now, like China, India, UK, and US, initially when it struck, everybody was running right, left to save an acute situation of patients who needed ventilators and the like. But in the process, there were definitely pregnant mothers. And so the questions are now being asked, what is the impact of COVID to pregnancies? And that is why we are talking about maternity. We have various studies, various guidelines, but as I said, their recommendations may not be really evidence-based because of the numbers of cases that they managed to handle. The UK, they have a series of pregnant mothers. They managed about 430 of them, and they're able to tell us a few things about COVID. We have guidelines, including our own Ministry of Health now has guidelines to do with the management and response to COVID and how we are prepared for this. There are issues you can see here of vertical transmission. You know, HIV stayed with us for long before we realized that we were actually having vertical transmission. And by the time we learned that, a number of babies already were infected. So could there be another, is this also another opportunity for this? But those are some of the things I probably want to just highlight. The direct effects on reproductive health. Does pregnancy change the progression of COVID-19? Does it make it worse? Do pregnant mothers present a worse scenario than the non-pregnant mothers? The answers that are coming through is that as much as we know there are immunological changes in pregnancy that may be associated with more severe symptoms, there is none that has really been very specific to this point. And the proportion of pregnant mothers getting admitted to maternity units is just like from the normal population. So, I mean, it's not really much of a difference. And the incidence of mortalities is not really as increased for pregnant mothers than the normal population. Similar findings were found with SARS and MERS when it was found in Korea and the like, but this time will tell, as I earlier said. But specifically on pregnant mothers with COVID, there are issues that may mimic. The issues of diagnosis are becoming a problem because we are aware of the changes in pregnancy that are standard, the physiological changes of pregnant mothers, including cardiovascular changes in adaptation to the pregnancy, the respiratory rates, and the tidal volume changes in pregnancy. And this sometimes may make people who are just normally physiological, they are just having a small dyspnea because of pregnancy, and then you find a health worker running away from such a person, or the person herself fearing that I have COVID, and yet you don't have it. Number two, they may also delay even diagnosing COVID because you may think it's just a normal shortness of breath, but then you find it's COVID-19. The fever that is associated with COVID-19, could the patient be having just a mere urinary tract infection? I mean, are we seeing patients being shunned away from hospitals or being suspected to be COVID positive because they present with any febrile illness that we have been experiencing normally in pregnancy? So these are some of the challenges we are going to be ready to face. There are medical conditions, of course, like cardiac disease patients. There are patients who will have pulmonary edema due to preeclampsia. There are patients who may have pulmonary thromboembolism in pregnancy due to DVT. How they manifest, the respiratory manifestations are really the same as could really be like the ones of COVID. So it is getting to a point where we must be clinically alert and have a high index of suspicion so that we don't miss out this diagnosis. And also we don't stigmatize or over label mothers who are pregnant and having genuine medical conditions, and then we end up losing them. The worst scenario is that you can actually have coexisting COVID with, say, a pulmonary thromboembolic condition or a preeclampsia or a cardiac disease. And that becomes a bit more of a challenge in terms of management, and the prognosis is worse in those kind of conditions. So those are the challenges that we need to grapple with as we take care of our mothers in maternity and the like. So I've already talked about the vertical transmission, mother to child transmission. there are reports. We've had babies who have been found to be positive within 12 hours, 24 hours, or 6 weeks of birth. And so the question is, are we having mother-to-child transmission? So far, the evidence speaks in terms of these. We have a few of them mentioned, but nobody has found the virus in the placenta or of the genital systems of these mothers, and to warrant us saying that there's vertical transmission. But as I said earlier, the numbers are very few. We are yet to declare what actually happens. In terms of neonatal outcomes, there has not been any significant bad outcomes unless there was an obstetric problem. And in terms of breastfeeding, as it is also, there's been thoughts. There are people who are showing, studies are showing a bit of secretion in the breast milk, but many of the studies have shown none. So these are isolated one or two, very low to comment, but it causes us to think about it. And so even if you find it is there, how much will it be that can cause a baby to get infected? Do we continue breastfeeding? Do we stop breast milk for these babies? And those are the questions that we are asking. So looking at best practices in an obstetric unit, what are the things we really must emphasize on our part? One is to ensure that our mothers coming to our facilities are not exposed. They don't get COVID. When they come to the clinics, when they come to the hospital, we need to protect them. The next one is to provide safe, personalized, woman-centered care during this time, so that mothers don't lose opportunities on their otherwise normal reproductive health care services. Let COVID not displace the standard care of practice in obstetrics and gynecology. And then finally, we must also engage and take care of the mothers who are actually COVID positive. Are we going to shun them? Are we going to take care of them in their homes? Are we going to take care of them in isolation units? Are they coming to share the beds with our mothers in the general facility and the like? So those are the things that we need to take care of. And the emphasis, I'm sure, as we already know, the issues of washing hands, observing social distances, putting on waterproof masks and the like, those will go a long way in mitigating against the first part that I've just shown there in terms of reduction of exposure to our mothers when they come to the hospital. We need to protect pregnant mothers to make sure they don't get the virus. The national, as I said earlier, the Ministry of Health has gotten its guidelines on this, and it's available even online. Somebody wants to go through them. They are really, it was an early reaction to the COVID pandemic, and so as a government, I think they had to be prepared. We are prepared for this, and it talks a lot about the mothers coming to access the normal standard care of antenatal, postnatal, and intrapartum care. The issue of testing, there are facilities that are insisting on every mother coming to a hospital, you must be tested for COVID, but I'm sure we all understand the challenges we have currently in terms of availability of test kits and the like. That may not be very feasible at the moment. So what we are recommending is that we need to screen our mothers, of course, with the thermometers as they enter the facility. We need to take history and understand the symptomatology, a fever, cough, and the like. I mean, just have a high index of suspicion. Instead of testing every other mother who comes, we need to pick out a few of these symptoms or signs that will cause that. In terms of the health facilities, we need to try it, we need to be ready for them. There are hospitals, as we talk in this country, which we have, the maternity wards are really quite packed. The social distance is not being practiced. We even get mothers sharing beds. So these are the things that we need to change. It's not going to be work as usual. People need to change. Disinfection of the beds and the linen and everything that we use. That is another aspect that we are recommending. Delivery in skilled health by skilled health workers is something that we still also emphasize on. let people come to the hospitals to give birth. We need to reduce these home births that I already talked about. But the health workers are also exposed. So we need to test health workers so that they protect patients, so that we protect health worker to health worker, and then still embrace infection prevention control practices, get PPEs available, readily available for everybody working in the maternity units, teach them on proper use of the same and handling of the same. All the way up to the time we are talking about theater. There was a reported case in this country at Kenyatta University Teaching and Referral Hospital where they had a cesarean section done. And the staff had to be prepared. You had to be gowned, and that's the time you'll know that those huge, the suit that we are using can really be hot and very uncomfortable during surgery. But that is the way to go. That is the new order. And then encourage hospitals actually to adopt disposable linen when they are attending to patients. If you go around the country, many of the hospitals, particularly the public hospitals, they still use a linen that is recycled. You wash and sterilize and autoclave and use again. So there is a new normal that we need to adapt to. Then in terms of the principles basically for management will include early isolation. The question is, where do you isolate these mothers? If somebody is COVID-19 positive, we should not treat them like the normal patients who come with severe acute pyelonephritis and admit them in the labor or on the maternity ward. This should be taken to the isolation units that are provided for in the hospitals. And then at regular intervals, because it's a multidisciplinary care, the obstetrician and the team from obstetrics need to visit those patients there. They only come to labor ward if they are coming to deliver or you're going to go through a cesarean section. Of course, I've talked about infection prevention procedures. We've talked about oxygen therapy needs to be readily available for this kind of patients. The fluid overload, as I said, this cytopathic reaction is a lot of leakage from the blood vessels due to the immunologic reactions that have been reported, and it can easily cause the fluid overload, the pulmonary edema and the like. So even when you're using fluids, we need to be really well controlled. The use of empiric antibiotics, particularly we've talked about the fevers and the like. The low molecular weight heparin is now highly recommended for pregnant mothers because as much as we know they have hypercoagulable states, they can easily in normal times go into clotting, and now compounded with the kind of immunologic reactions that COVID presents, they are at higher risk of developing venous thromboemboli. So prophylaxis for this kind of patients is important, but of course we talk about you need to do a VTE score before you decide on using this. Fetal monitoring should be as standard as possible. There are a few studies, I think, was it in China or somewhere, where they talked about bad fetal outcomes and on COVID patients. So as much as the evidence is still weak and we have more saying there's no difference in terms of fetal outcomes and fetal distress and the like, it is good to be vigilant as usual. But whatever we are using, be it continuous electronic monitoring, we need to sterilize all those equipment and all. Their mothers, a very small percent from the UCO study, they said about 1% of those mothers will need ventilatory support, mechanical support. Hospitals need to be prepared for all this. When it comes to delivery is now the other challenge. It has to be individualized. We don't want to have a blanket that every mother who is COVID positive must go through a CS, or you must induce them so that they go on to the care that they are being taken care of. It is good to individualize. Let's have obstetric indications for delivery. Elective inductions, I think they are being discouraged. Cesarean sections you do where there is an indication. However, in very severe forms, there is respiratory embarrassment and the like, you may be required to deliver them early. So elective, as emergency cesarean sections have been done before pre-labor, just for the sake of getting the mother to be resuscitable. And mode of anesthesia recommended if you can do regional anesthesia, but I've said earlier there are complications of coagulopathies that people need to be aware of. So you really choose the method of anesthesia with an understanding. Studies have also reported about the postoperative recovery of patients who are COVID positive, be it gynecologic or obstetric or any other surgery. There have been challenges in terms of their morbidities, and that is another thing that we need to be aware of. But what I want to emphasize is a multidisciplinary approach that we need to encourage. These are innovations. Guys are innovating. That's a labor ward, and you can see there is this is in Turkey. The two health workers are delivering this mother, but you can see there is a shield round on top of the face. There is, you deliver under a good mask in a chamber that you reduce transmission and infection of the health workers and the other patients around. So it's calling for innovations, and people need to really move. Breastfeeding, I've already talked about it. We need to support these mothers to breastfeed their babies. There's no need of isolating the newborn baby. What we insist is hygiene. The mother needs to wash their hands. They need to be on a mask, a good mask, and they are careful. As I said earlier, the shedding of COVID-19 in the breast milk has not been proven. So breast milk is still very safe. But if ever it will be proven, we still want to know what quantities, and there are people even exploring, is there a reason to pasteurize this milk if at all we'll ever get to have the virus there and the like. The advantages of breastfeeding are still quite the same. So we need to really continue with that. And in terms of, we know the medications for treating COVID-19, we still don't have a cure for this disease. We've had all these names mentioned all over for trying treatment. Today it's tried, it's dropped tomorrow. And in pregnancy, we know we are worried about what is the effect of these drugs on our pregnant mothers. So we need to think about them. Azithromycin has been mentioned. I don't know its effectiveness, but in terms of pregnancy, it's fairly safe. Hydrochloroquine, there are studies which show no risk really. Others have classified it as a drug that you don't want to expose mothers to. The antiviral that has been proposed for its use, we have very limited number of pregnant mothers who have used remdesivir, and so we don't really know much about how safe it is for pregnant mothers. Dexamethasone is now the new kid in the block for severe respiratory infections. For those ones who are very severe, moderate to severe conditions, they have been shown to reduce the duration of intensive care and all those. So there it is. What we don't know is the duration of its use and at what point you want to start it. So dexamethasone, fairly safe, but it's a steroid. If you have prolonged use of this, we know the effect it has, particularly on the fetus. Vaccines, we still don't have a vaccine that has been promising. And so those are some of the issues that I think we need to keep our heads open to, and probably as we propose research and other things, those are the things that people need to start thinking about, researching around, so that we know what works in our local setup. Let's not really copy and paste from China or UK and the like. Otherwise, in a nutshell, we just need to ensure that everybody has adequate access to all maternal and child health services at all times, despite this COVID period, because birth plans are key and crucial. We need to have a referral system. You know, initially when we had the lockdown, we had like the curfews and people are not ready to move from one place to another. At the start, it was like a period confirmed, you can't move from A to Z, but communities need to work out preparedness, have transport ready and all those kind of things. We must lobby for more resources. As you've seen, there are a number of things, PPEs and isolations and more beds in maternity. We actually need more maternity units for social distancing purposes. It's not going to be the same, so we need more funds allocated for maternal and child health, even in these times. And of course, for every health worker, high standards of of care in this process. Let's not neglect our patients, let's not stigmatize our patients. And of course, our staff. We must reclaim their morale, we must encourage them, we must ensure they are safe so that they work with their normal confidence, if at all we are going to move into the new normal. So really, those are the points I wanted to raise, and thank you all for sparing your time to listen to me. Thank you so much.
Thank you so much, Dr. Otara, for the very good presentation. Our participants are requesting for your slides, and the Secretariat shall be sharing with the participants of this webinar. And this presentation shall be available on our website, on our e-learning platform for those who are not able to catch up. Without further ado, because of time, I'm going to introduce our next speaker. Our next speaker is Dr. Kali Odula. Dr. Kali Odula is a reproductive health specialist with over 20 years experience in her field with exposure to a wide range of reproductive health issues. She's a senior medical specialist based at the University of Nairobi Health Services. She has successfully held various executive positions in the Kenya Obstetrical and Gynecological Society, COGS, as well as the Kenya Medical Women's Association, KEMWA. In the recent past, she chairs the board of directors of Rodenkill Cleaning Co. Limited, as well as the Coalition on Violence Against Women, COVAL. She's a Honorable Secretary of Kenya Medical Association, Nairobi. Welcome, Dr. Kali Odula. You have 15 minutes to go. Thank you.
Thank you, Liz. You have a lot of detail about me. So I really appreciate Kenya Medical Association for this time that you've given us. I appreciate Professor Nyunya, who is our team lead. Dr. Amos Otara has done a wonderful job, so my talk will be strictly 15 minutes. So I'll start by going by it through the other way around. I want to appreciate Dr. Otara. I want to appreciate that I got most of my information from the Kenya guidance, the practical guidance by the Ministry of Health, as well as the interim guidance on the continuity of services during COVID. These are both recent documents. The first one released in April and the second one in May, just this year. As well as I got a lot of information from our own guidelines at the Nairobi Hospital for Obstetric Care. That was in May this year, as well as a technical brief for maternity services from UNFPA. The Royal College do give us a lot of support, and we tend to glean from these documents. So I think that, you know, as much as we've learned so much, and Dr. Tara said that, we must get our own data. How do we get our own data? But by looking at our situations and trying to find out ways in which we can deal with it. And he mentioned some about, you know, increasing the maternity space and all that. So like I said, these guidelines are aligned to Ministry of Health documents. WHO, of course, we're having a lot of conflicting statements here and there from WHO. CDC, as well as multiple professional associations, colleges, and societies. So these resources will provide us evidence. What do we need with this evidence? We need to use the evidence to put it to good practice, as well as use expert advice. What are priorities? Dr. Tara, I must really emphasize, you mentioned this before, the top priorities remain, as you said, prevention of COVID-19 to pregnant women. Prevention. When they say they will not come to hospital because they will, you know, get COVID, it's not as if COVID is hanging around in the hospital walls. Let's tell them, come to hospital, we'll prevent you transmitting, you know, others who are positive transmit to you. We want to provide safe care. Safe care, all women, suspected, confirmed, our normal healthy women, we must make sure we provide safe care. They must go home to their families safer, not providing a situation on an environment whereby they will go home and transmit to their innocent families at home. Our health workers are key. Our health workers are the face of this disease, because they say, don't rush, don't rush. Are we listening to this advice? Don't rush. Are we really listening? Don't rush. Don't rush. If you have a case, get ready, prepare. If you do not plan, if you don't plan, you will fail. So if your health workers have never, ever been in a situation where they've learned how to don, how to doff, areas of donning, areas of doffing, they will fail. So the first thing is, before we go out there, we have to be taught the right way of doing things. What is the right way of doing things? Is practicing, and practice does make perfect. Now, I have now turned things around. I said, protect our providers, protect our workforce, protect. How do we protect our workforce? Training. At the health services, we had a situation whereby we had to use these PPEs. We were told, what is this? This is the goggles. This is the hazmat suit. This is the way of donning, closed donning technique. If you're rushing to save a woman and you're not fully prepared, you're exposing your family. That is a no, no, no. We're providing a safe and effective maternity care to our women. That also has to be put in place way before. We maintain and protect systems. Dr. Tara, you talked a lot about this. We need money, we need to invest, we need judicial use of these services so that we are able to cater for a large number of our women. If I go strictly directly, because Dr. Tara has done a lot of good work in the few minutes that he was given, I want to go to the labor room preparedness. Before they reach the labor room, at the entrance of the hospitals, we have people who are taking temperatures. Are these thermoguns, are they working? Are they really telling us the situation on the ground? I've seen somewhere in the chat, somebody's asking, are we screening all women who are pregnant for COVID in antenatal clinics before they come into labor? No, that would be expensive. That would not be good use of our few and available kit. So is the thermogun telling us the truth? Is the woman giving you a correct history? Has she traveled? Has she been in contact? Is there anyone around her who has a fever? Is there anyone around her? I even recently realized a client who came to my office did not have fever. She didn't have any fever. She said, oh, I'm just a bit tired, but her stomach was running. And that is, as we say, a new manifestation. I love the diagrams that Dr. Tara, showed us there, very beautiful. I want us to go further and deeper. This African setting that we're saying our women are not having very severe symptoms. This running tummy, could it be one of the things that we may have missed? How do we provide safe services to a woman presenting in labor who does not have respiratory symptoms? And she's continuing in this same space where other women are. We must pay attention to our infection prevention practices. Do you have stock of PPE? Dr. Tara, you mentioned, staff running away because someone is query positive, whatever. Why should they run away? If they're confident of their status, they want to help. That is our calling. Get your PPEs, don, get ready. Make sure your labor room is very clean. We are trying to do a bit of masking so that the aerosol production, as a woman is pushing and all that, in labor is not so much. I think the judicial use of a bit of a low dose spinal anesthesia may not make her produce a lot of those aerosolized materials. We say she can have one person to assist her during labor, the husband or, somebody can assist her just to be on this side to give her courage, maybe remove the mask when she's not breathing so well, give her a bit of oxygen, give her a bit of water to sip. All your surfaces should be clean in between the deliveries. All your surfaces are clean. I walked into a situation, some office where everyone is wearing gloves, disposable gloves, and every few minutes they are spraying themselves with sanitizer on the glove, and they're touching everywhere. They're not changing gloves in between talking to people as well as touching surfaces. Staff should follow regular hand hygiene practices. Our sanitizers will never replace hand, soap, and water. 20 minutes. Sanitizer is not the solution to this. It is our own personal ways that we're protecting ourselves with, and soap, running water for 20 minutes. I want to go directly also into intrapartum care. These women, I know Angela is going to deal with it. They need respectful care. Whether she's positive, whether she's suspected, whether she's negative. You're not going to have a different set of ways of giving our respect to our pregnant women. Things are not going to change. We're going to give all our women care. All persons coming into our labor rooms must be screened for fever, shortness of breath, as well as every 12 hours we keep checking this temperature. It may be normal right now and then shoot up within a span of, Cindy or Dr. Tara, just one temperature check may not be sufficient. We must minimize movement. We have to say, okay, Sawa, this lady is called COO, she's in labor. We'll have 2 people assigned to her, nurse so-and-so and nurse so-and-so. Not 4, 5, 6, changing. That will make us use too much of our PPEs and also going to cause wastage. Minimize movement in and out of this room. Make sure the room is well ventilated. During the triad, we're always encourage the use of appropriate PPEs. We want to look out very fast. We're looking out for hypertensive disorders like neurological diseases, metabolic diseases, diabetes. We want to look out for GI diseases, endocrine disorders, cardiac, of course, like you mentioned. HIV is not out of the window. HIV is real. HIV is real. Rule out simple things that can cause us to miss out this fever. Rule out urinalysis. A simple urinalysis can tell you, oh, what's happening here, and you mitigate, use the appropriate antibiotics that will clear the UTI. Respiratory disease, renal disease, as well as hematological disorders. For the obese women, those ones will need, of course, advice moving forward. What I'm trying to say is, this woman is a whole human being. So we are looking for a multidisciplinary approach. You need the pulmonologist. Please, in any situation where you have a pulmonologist on the ground, please consult. If this woman is hypertensive, heart cardiac, call in your colleagues. Don't suffer alone. Let's have our best outcomes for our women. I'm saying the same thing. All pregnant women, suspected or confirmed, have the right, because they are a human being, they have the right to high quality of care. We say this, but we say, oh no, but this one has a septic abortion, so she doesn't have the high. No, all women have the right to high quality care. Before, during, after. Her mental health has to be taken care of. The newborn needs to be taken care of. Let's treat this woman as a wholesome woman who has come to us. She has trusted us. Let her go home with a very good experience. So what are we saying is a safe and positive childbirth experience? Back to the same thing. Recently, a woman complained, I was treated badly. People were not professional. For a woman to give you feedback, she has taken time to think about it. She has gone home. She has come back and said, look guys, I wasn't treated well. That one woman is going to mess up your name. Don't allow that. Don't allow that. Treat them, everyone, with respect, with dignity. Communicate. This is what's going to happen. These are the people taking care of you. You've come in for maybe severe PT. We're putting in a tablet. How long will this tablet take? 6 to 8 hours. If it doesn't work, we may put in a second tablet. If we're able to rupture the membrane in the simplest English, which she can tell her grandmother, there in Bungoma, in Rusing Island, oh, the nurse, the doctor told me within this and this and this time, if things don't move, they'll have to intervene. We'll have to change our tact, give them the whole thing. That is why we're there for them. Give them time, talk to them. Appropriate pain relief I talked about. We can try a bit of the Entonox. We can try spinal anesthesia so that the woman is comfortable. If she wants to walk around during labor, allow her to do that. Allow her to do that. Look out for people, look out for diseases that can make her experience not so good. Like I said, mobility as well as birth position of choice. If a woman is suspected or confirmed, we as health workers, I am saying the same thing. Take appropriate precaution. Don't run away. You're trained, you're confident. This woman has come to you as one, they have to leave 2 people. At a company, twins, 3 people. She has to go back to her family, to her children. Take appropriate precaution. You have to go back home without risk, without exposure. You're going back to your children, to your family. Someone asked here on the chat about the mode of delivery for COVID, suspected or positive. No, the mode of delivery should be based on your Common obstetric and medical indicators. We're not going to change things because this one is suspected. Let's get her out of the way. Run your operation faster. Pana. We must give her what she deserves. If she is a 2 previous cup, you know, this is a case of repeat cesarean section. Don't delay her delivery. No. She may now end up with even a morbidity or a mortality which you're not ready to deal with because you took care of her last. She's the 10th patient. The whole staff is tired because she's 2 previous cars are baki apana. Let her have the cesarean section. Let her have spinal anesthesia. Let her have oxygen. Let her cover her face with, the person giving anesthesia should be ready to convert to general if the spinal anesthesia is taking too long, because we're going to make the baby inside go through more than what we expected. If the spinal is not working, apana, make sure anesthetist, everybody covered, minimal time. The person doing the cesarean section should not be our novices. It has to be somebody who's going to remove our baby very fast. Baby goes to where pediatrician is waiting or the nurse taking care of the baby. We're not really making her exposure in theater with her abdomen open and all this too long. The most experienced person come in, do the operation and let them get out of that theater. Clean the theater, wait for about half an hour, ventilate, and the next patient can come in, irrespective of the mode of delivery. Hand and the breast hygiene must be maintained. In fact, now we are really recommending don't hand the baby to the mother until she has really cleaned her breast, she has cleaned her hands, she has masked. If she's too sick, don't make her breastfeed by force. No, give her time. Give the baby away to another caregiver who can, as Dr. Tara mentioned, she can express her milk and the baby can be continuously given this nutritious milk that is really God-given. We have to practice what we're saying, managing an acutely ill patient. Initially, the ministry said we delay electives or we relocate them. Right now, when you're putting everything in place, there's no reason why you should delay electives. There's no reason why we should relocate our suspected or positive if we are putting in the right things on the ground way before. Vaccination, immunization should continue except the mass vaccinations, which should be temporarily suspended because of this too much point-to-point contact. Give our women their contraception of choice. Don't deny them commodities. Don't deny them. It's their right. They are in their families, they are having relationships. The relationships did not stop because COVID came through the window. No. People are having sexual contact. They need to be ready to take care of the choices and the numbers of children that they like to have. Those who come with emergencies, including incomplete abortions, and they're positive or not, give them their care. If you're not going to give them care on time, it's up to you, because if something wrong goes out and she has an unfortunate incident, it will be on your head, honestly. What are we going to do in antenatal, maternity, and postnatal services? We screen and assess the way we normally do. There's no difference. Waiting area, waiting room, make sure there's social distancing. Is it physically? I don't know whether there's social or physical distancing. Make sure you have well-aerated waiting rooms. Schedule the patients so that they're not crowding. You're not going to be the reason why patient A and patient C, got infected in your waiting area. Go ahead, give your supplemental iron, folic acid, calcium, protect from malaria in endemic areas. This is very important. Look out for these things before. Look out for hypertension. Look out for preterm labor. Give them what they deserve. Dr. Tara mentioned dexamethasone. So I guess in a positive patient, then dexamethasone, and if she's in preterm labor, she would of course benefit double ways. Look out for other fevers that are happening. Abnormal pregnancies, high index of suspicion, save our women, positive or not. You know what are the right procedures to use. This is a Ministry of Health document as I continue reading. Labor induction and monitoring as per normal. If you're going to use an ultrasound, if you're going to use a CTG, all those things, clean. Make sure all your surfaces are clean in between patients. Don't cause cross-contamination. Follow your infection prevention procedure to the letter. Those indicated for normal vaginal delivery, endelea. I love that Turkey labor room that Dr. Tara shared, very beautiful. Those who are supposed to go for cesarean, go for it. Obstetric emergencies are there. We need to learn more and more and more about vertical transmission. So as studies come up, I noticed one study in South Africa, another one in China, where the neonate was found to be positive, I think within 14 days of exclusive breastfeeding. So would it be that the mother transmitted through her breast milk? Was it through her uterine fluids? I'm not sure, but there were two studies. One in South Africa and another one. Okay, moving on swiftly. This is just a big algorithm, which I think most of us should really take a look at, because we are only, it will help us in times of an emergency. In an emergency situation, you want to prevent droplet transmission, okay? You want to prevent droplet transmission in an emergency surgery, but she needs surgery. Let her go in immediately, don't waste her time. In urgent procedures, you have to, strategize and prioritize into high risk or a low risk procedure. Look at the symptomatic presentation of the woman. Consider a delay if there's a positive correlation. If it's negative, go ahead. The highest risk now would be to our anesthetist. And we're trying to say, try and do most of your planned or emergency procedures under spinal anesthesia, and everyone must make sure there's no droplet infection from the patient, from the staff to the patient. In low-risk procedures as well, do your symptom screen, positive, consider delay, standard, proceed, but make sure you have your PPEs. All this goes all the way down. And our high-risk procedures, as I'm sure you all know, ENT, bronchoscopy, endoscopy, bowel surgery. In fact, I know of a lady who has gone in twice for bronchoscopy, and the results were negative. The third bronchoscopy reveals positive. Anyway, any provider operating on a high-risk patient must have training on appropriate PPEs. You must have training. The people cleaning our rooms, don't forget about our people cleaning the rooms. We must take care of them as well. They should not be left out in training. Let's train everybody. Let's train everybody. Let them be comfortable. As they give you a clean operating room, they give you a clean labor ward. You appreciate them. I got this, minimum staff and equipment to be availed pre-op. An operating surgeon, bare minimum. If you have one, fine, and a good assistant, competent, and like I said before, the aim is to use the shortest time possible. 3 scrubness, maximum. Don't have the place full. Oh my God, this is a COVID patient. Hey, let's come and see, let's come and see. Apana. We're having minimum number of patients, number of staff. Scrubness, circulating nurse, runner nurse. Anesthetist, as assistant, as well as clinic personnel. Look at the estimate of PPEs. 14 gloves, 7 gowns, 7 face shields, 7 masks. Imagine if you're doing 10 surgeries per day, and these patients are going to, they're going to incur a lot of costs. Really, we must find a way of making things work in an environment where we're going to save on costs as well. And those are my references. As I said before, may have passed my time. I want to stop there and again say, Asante-san. Thank you.
Very much, Dr. Omila, for that very good presentation. I'm sure the physical meeting would be clapping for you, and that one for putting flowers, blue, pink, red. Yeah, thank you very much. Thank you, Dr. Otara. So we move to our next presenter, and that is Angela Nguku, and I'm going to introduce her. She's the founder and executive director of the White Ribbon Alliance in Kenya. She doubles as the African advisor for the White Ribbon Alliance Global. Passionate about maternal, newborn, and adolescent health, Angela's career spans over 15 years of dedicated work towards ending preventable maternal and newborn deaths globally and amplifying the voices of marginalized and vulnerable populations in Kenya, throughout Africa, and around the world. She's a graduate midwife, an accomplished thought leader. She combines her proven influencing and negotiation skills in advocating for the accountability of health of mothers, newborns, adolescents, as well as midwives. She has a background in nursing and midwifery, masters in midwifery leadership, and a master's in project planning and management, and holds many certificates, including in policy, advocacy, and accountability for health. Angela, a Bill and Melinda Gates Foundation 2018 goalkeeper, has written various articles on the need to invest in maternal and newborn health, why quality healthcare defined by women and girls' self-expressed needs matters in the UHC era, and most recently, why COVID response should not overshadow maternal newborn healthcare, among others. So welcome, Angela, to take us through the next presentation, or to speak to us about dignity and respect to our mothers. Welcome.
Thank you so much, Mariah. That was quite a lengthy intro. Thank you so much, and I'm happy for, I'm also learning also from Caro and Dr. Otara, my previous speakers. And in this forum, I'll be talking about issues around dignity and respect as defined by the citizens themselves. I don't know how many of us know about the Respect to Maternity Care Charter that was recently updated to include mothers and newborns, and talks about the 10 rights that women and girls and mothers and newborns in the labor ward or during the whole continuum of care should actually be adhered to during that care. And with COVID, that doesn't mean that changes. And I will start by saying that as White Ribbon Alliance last year, we conducted a survey, it was called the What Women Want Survey, basically to understand what quality of healthcare means, quality of reproductive healthcare means to women and girls. We did that because I think all of you are aware of the survey that was done by the Ministry of Health to talk about why mothers were dying in childbirth, the confidential inquiry into maternal deaths in 2018. And quality of care or substandard care was reported in 9 out of every 10 women in Kenya. And so as White Ribbon Alliance, we went further to find out from women and girls in Kenya, why are they not going to health facilities? What is happening in the health facility? What does quality mean to them? And so when we talked to these 120,000 women and girls across the country, we were surprised that water, sanitation, and hygiene took center stage as the defining factor of quality for them. And that meant clean toilets, clean latrines, linen should be clean and all that. But what stood out for us mostly was the fact that respect and dignity remains a far-fetched dream for women and girls in our labor wards and in our clinics. And so we wanted to understand, even during COVID, what is really happening. So we know that pre-COVID, that was the issue. And yet we know that the Respect to Maternity Health Charter talks about rights of women and mothers during labor being upheld. We went ahead again during COVID and took a survey in 6 counties. And I've actually realized that during COVID, things have even gotten worse. We thought maybe things were getting better with the UHC perspective, but we realized that women and girls' dignity and respect was still not upheld during COVID. And so I'm going to share with you some of the things that we heard from women and girls. And I think my previous speakers have alluded to that. The issues around not being called by name, that is basically what Mara is sharing is basically our findings from the What Women Want campaign in Kenya last year. And so women told us that they wanted to be talked to. Women want to be told what is happening. So our health practitioners, the whole healthcare team, and it was not discriminative, but it was doctors, it was midwives, it was clinical officers, it was a nice set, the long word, that one. So it was basically the whole healthcare team was not responding to their needs. Women want to be part and parcel of deciding care. Women want to be called by name. They don't want to be addressed as that woman suffering from COVID, that woman suffering from HIV, that woman, they don't want to be called by codes and the like. So there's so much that we had. They want to be smiled to, they want to be explained to. So that is what was happening even pre-COVID. What are we hearing during COVID? We all know that, and health workers, we all know that pregnancies do not stop with pandemic, and so it's labor and childbirth. And that ends such that you and me, who are decision makers in the labor world, should ensure that right to dignity and respect continues to be upheld even during COVID. There has been reports of violations, not just in the labor ward, but across board, even even by the different in the different counties and in the different hospitals, that this is ongoing. This is happening even as we are talking about COVID. We have seen places where, on a large scale, I'm outside now the labor ward. We have seen resources and health workers taken from the labor wards to the COVID response. We have seen maternity units being transmitted to become the COVID isolation rooms. We have seen compromised prenatal, antenatal, and postnatal care. We are seeing medically induced C-sections, because women are telling us when they go to the health facility, for those who get to know, because most of them are afraid to go to the health facility, they are being rushed. They are told, you know, you have to get out of this place very fast because you will get COVID. So there's that fear factor. Instead of us giving women, and all of us here understand the whole complications around, the whole anxiety that comes with labor ward, pregnancy, all that. Some of them are primary mothers and the like. And so they are being rushed. There's induction going on, unnecessary cesarean sections, augmentation of labor, which is not necessary because women are being hurried up to get out of the health facility. More to that, we are seeing women being sent home even before they finish their time in the, as much as we want to say that women need to take the least time possible in the health facility, we also need to ensure that they are given the necessary information, they are taken care of to a point where they can actually be assessed to go home. We have heard of cases which have been reported to us of women who started bleeding after they left the health facility because they were discharged immediately after they delivered. That is not what my previous speakers were talking about. And we have seen mandatory separation of the baby and the mother. We know very well that they start immediate whatever. My words are disappearing from me. We need to ensure that the newborn and the mother actually are together even after delivery. We want to ensure that immediate initiation of breastfeeding, but we are seeing in some institutions that is not happening. Women, they are being separated immediately after childbirth. We have seen companions at childbirth they are being turned away. We know how important companions are important. Partnership is important during childbirth, but that has been taken off because of the COVID response. Not because it's backed by evidence, as Dr. Otara was talking about, but because we think that is what is good. But is it good for the mothers and the newborns? We have seen hospitals creating their own guidelines. Dr. Odula has talked about the Ministry of Health, the RMNH guidelines, and I will be happy if all of us can actually get to those guidelines and the latest that have been sent about what is it that we ought to do. And the WHO website keeps on having information coming in that we need to pass ourselves with, but that is not happening. We have seen in different institutions, we are not complying with the central evidence-based guidelines that the Ministry of Health is giving. We are coming up and creating our own guidelines, including how we are going to deal with all these mothers. And of course, the other issue around seeing midwives and doctors not having the PPEs such that even that they're exposed, that means also the mother is exposed. So at the end of the day, we are seeing, even during COVID, there's so much of that violation. What does that mean for us as health care workers? There is a necessity. It's important that we actually get to respect and dignity. We need to ensure that we don't use COVID to actually expose our women to indignified care and disrespectful care, as we are seeing in many places. Let me talk about now the ANC and delivery in health facilities. And I'll refer to the current, the survey that I talked about that we just carried out in 6 counties. Women are telling us that they have been told by health workers that they should not go to the health facility because they'll contract COVID. I do not know, as nurses, midwives, doctors, clinical officers, as health workers, where is that information coming from? We are meant to be encouraging so that we can be able to give the best care possible to these women and girls. But why are we putting much more fear to this? We had already made such gains in the country in terms of what is it that we need to do to stop these deaths that we are seeing, because Kenya is still recording very high maternal deaths. But now we are seeing more women are stopping going to the health facility. We have more increased cases of home deliveries. And some of these are because we are not giving the right information, or we are the ones actually pushing the women and to go further from, to move further from the health facility. So as health workers, we should be asking ourselves, what is it that we ought to do? And ensuring that we give the best, we are the best, we become the best companions to these women and girls. So for me, as the key thing that I'm advocating and pushing for is that I think it's better when we get the best using the guidelines and the evidence that we have to ensure that our women continue delivering in our health facilities, continue getting the best dignified care possible at the end of the day. Because if that is what it means to them, if dignity and respect is what quality means to those women and girls, do we want them to come to the health facility, or do you want to get them out of the health facility? I think I like what Dr. Odula talked about, cases of women being taken care of because of in the current era by the best, not by the students, but by the best of the best practitioners at hand, especially if they're high risk women or mothers in the labor ward. I have two cases of women, one now is in IHDU and the other one is in ICU, because they were given the lower cadre doctors to take care of them during cesarean section, and they ended up with complications. I'm not saying that this is not the case. What I got from those families is that they were rushed. It was done so fast, it was not indicated, it was actually like they needed to get out of this as fast as possible. So is that the care? Is it that we want to see our women, our mothers ending up in ICU and HDU? What are the economic implications? What are the psychological implications to those families? I think WHO, and I know the Minister of Health in Kenya has actually relied on guidelines that are context specific for us based on what the WHO has given, that we need to ensure that our guidelines are evidence-based. We don't just come up with rumors just like everyone else, to come up with things just to ensure that we get these people out of our way. Comprehensive respect to maternity care is necessary. Not just during this time, but all the time. But I think now it is much more necessary because there's so much that is at stake now. So we ought to ensure that the respect and dignity that we would want ourselves to be according is according to our women and girls. And more to that, even the newborns, because for the respect to maternity care charter to be revised to include the newborn, is because the newborn was previously not considered as part and parcel of the mother, of the labor ward, of the newborn ward. So at the end of the day, I think we need to be able to embrace. And I'll be happy to share some of the resources that are on our website, and also point everyone to the WHO website around these guidelines that I'm talking about, the respect to maternity health charter, and help every health worker to be aware of them. Because talking to some doctors, some midwives, some nurses, but basically the healthcare team, what I got is that most of them, some of the things they do because they do not know, actually they are disrespecting the mothers. So I think there's also the element of ensuring that we get to understand what is the practice, what are these rights that we are talking about, and where do they go, up to what extent. If we make decisions, why don't we tell the mother the decisions that we are making? If we make decisions regarding, for example, a cesarean section, why don't we explain to this woman what is the implications of the same before we do, as we go along and doing that? And I know during my training, I was told that information, I must disseminate information, I must share information, I must get consent, I must ensure privacy, I must ensure confidentiality, I must ensure that all that I'm giving is actually backed by evidence. So when did we stop that? When did our start change? And I'll be able to hear from the able professor and the doctors who are still in the training institutions. Has that changed? Does that mean that we have changed because maybe the workload is a lot? Have the ethics changed? Are we now able to decide that we can give whatever care we want to our women and girls without really asking them whether that is the care they want? From my training, what I remember is that the mothers are supposed to be part of the caregiving process. They need to be part of the care team because they are a stakeholder. So when did we stop now that and move it to decide for them, and yet they are able to make decisions on themselves? So I think there are issues that we need to start interrogating, and more so during this COVID, because this is when we receive the highest cases of disrespect in our labor ward. So at the end of the day, Maria, you can project the next slide. We need to ensure that we are aware of what are the guidelines talking about respect and dignity? Where are some of these resources that we can actually get to? Because they are there. When we talk to health workers in different countries, they tell us that they are not aware of this respect to maternity health charter and what that means to them. They don't have time. But our ethics, do they mean that we need to slap our mothers, to talk to our mothers worse off? I want to finish by talking about a population that I say today I'm going to talk about, the women living with disability. That is one of the cases that is abused most. One, because our health system does not respond to the needs of women living with disability in all fronts, whether it is in family planning, whether it's in the labor ward, whether it's NC and the like. when we were collecting the data, we got to hear from these women, and they told us that no one really prepares for them. First, it's like they're not supposed to get pregnant. So they actually abused. Why did you get pregnant? You know you cannot give birth. You know you are disabled. To me, I don't think that is the kind of practice that we should be having. So if you go to deliver in a health facility, there are no facilities that are for these women. It is a form of disrespect, because we are talking about equity in the UHC era, equity in care. But you go to those toilets are for the normal curve woman, the normal curve. The delivery beds are for the woman who falls within the normal curve. Where is the delivery bed for the woman with disability? When they go to the beds, even at the postnatal ward, even the labor ward beds, they do not respond to the needs of these women and girls. So are we supposed to assume that they don't exist? They don't have, when they go for family planning, they are told, no, you're not supposed to come for family planning. You're not supposed to give. Don't they have reproductive health needs? Do they have sexual reproductive health needs? So these are some of the issues. And now with COVID, it's even worse, because the interpreters that were there, it's like they are no longer there. So we have perpetually abused, indignified, and disrespected women, sometimes without our knowledge. And so it's high time we really interrogate ourselves, even as we look at the guidelines. Are they responsive to the whole population? We have women with mental disabilities, women with physical disabilities. We have women who are deaf and dumb. How do we ensure that their needs are actually addressed in the labor ward? And how do we ensure, even as health workers, are trained to address the issues of these women and girls? So I think as we go forward, as the healthcare team, we need to really interrogate ourselves and ask ourselves as decision makers, are we responding to the needs of these people, of the mothers in the labor ward, in the antenatal clinic, in the postnatal clinic, the way we should respond to ensure that at the end of the day, we achieve more healthier outcomes than we are doing now. And I want to finish by saying that we have a lot of resources in our website, on our website in White Ribbon Alliance, and also in the WHO website, that you can actually get most of that on respect to and dignified care during childbirth, and many more resources that are available for healthcare workers to actually embrace as we go forward. Thank you so much, and I welcome any questions should you have any. Thank you.
Thank you very much, Angela, for that very informative presentation, giving us new perspectives that sometimes healthcare workers forget to consider. And now we welcome our panelists. We'll start with Dr. Joy Mugambi, and we also have Professor Nyunya. Dr. Joy Mugambi is a family physician based in Baringo, a lecturer, Kabarak University, and she's the Assistant Secretary General for Kenya Medical Association, as well as a very active member of the Reproductive Health Committee. So Dr. Joy Mugambi, I'll start by asking you a question. Kindly enlighten us on the hierarchy of PPEs, that is personal protective equipment. We've had in some of the presentations, PPEs mentioned, and we would like to be enlightened further. Over to you, Dr. Joy.
Thank you very much, Maria, and thanks very much to the speakers who have gone ahead of me, my mentors, and the people who brought me to KMA and have really worked with me this journey, Dr. Otara, Carol. It's great to be here along with you. I retaliate. Yes, PPE is very important, but we also have to consider the hierarchy of PPE. I'll put up a slide here, a picture that depicts a few, I'll put up a picture of the hierarchy of PPE, because we keep asking for PPE. And if you look at that triangle down at the bottom, protection of the health worker with personal protective equipment, it's actually at the lowermost, least effective. Remember, there are certain things that have to be done administratively and engineering, substitution, elimination that need to be done to ensure that that individual at the workplace is well protected, because we only consider the mask, the gowns, and all those expensive stuff that we are buying, and which are also going to be littering our environment in a short while. Remember, administrative controls need to be put in place. The administrators, wherever you are, you need to ensure that you change the way people work, ensure that those rooms are well aerated, that those rooms where these mothers are delivering are well placed, the beds are well in the right places. So those administrative controls need to be set out by the administrators. Engineering, how do we isolate the people from the hazard? Are we, just as Carol Odula talked about the bed spaces. So when we talk about PPE, we need to consider all these hierarchies and then come into substitution. Are we replacing this hazard? Are we ensuring that these mothers are, probably we change the practice. Where I work, it's a sub-county hospital. The primary healthcare facilities are not doing much, where they could be delivering these mothers at the closest center and reduce the risk that these mothers would be encountering, rather than coming all the way to a tertiary center, which is maybe 100 to 50 kilometers away from their homesteads. How about elimination, removing the hazard from the place, ensuring that the COVID centers are away from the main facility where normal deliveries are being conducted, ensuring those isolation centers have a delivery room that would ensure that these mothers deliver safely. So when we talk about PPE and controls in terms of protection of that health worker, all this needs to be in place. Thank you very much, Maria. That's all I would say in terms of protection and the hierarchies. Do not forget them, because yes, we can simply talk about the masks and the hazmats and forget all other controls that we could put in place. Thank you.
Thank you very much, Dr. Joy. We can quickly move to Professor Nunya. And Professor Nunya, I'll invite you to make a comment on advocacy and policy in relation to maternal health and the labor ward amidst COVID-19.
Okay. Thank you very much. I think my colleagues, Amos, Kali, Angie, and Joy have done a wonderful job. It couldn't be done better. These are some of the most committed, most articulate, and very influential people like Amos, Kali, and Angie, who we want to incorporate into KMA start. I mean, that's a directive to Kigondo. I'm seeing Kigondo, the associate membership of KMA. Kigondo, I hope you are listening. Now, I think I will focus a bit, just add so that I touch on the advocacy aspects. And I think Angie has very, very clearly, talked about the human rights, the sexual and reproductive health rights, and the dignity of the woman in labor ward, the parturient, COVID suspected or in an environment. And it is coming very clear that some of the things that we have ignored in the past, like wash, the cleanliness of the environment, the aeration, the ventilation, those are things that we very many times take for granted. I go to very small facilities and you find a dedicated healthcare provider who has empathized with the labor process and are introducing things that do not cost money. Things like, welcoming women, preparing birth notifications for women, providing a cup of hot tea. Those are important things. So water, sanitation, hygiene, I think those are some of the things that post-COVID we must embrace and, learn things, that reduces most of the infection, not just COVID, most of the infections. And that brings me to the, the standard universal precautions. We should treat everybody. If he's not infected with COVID, he has something else. So when you are handling a pregnant woman and a woman in labor, you need to take all the precautions so that, hand washing, sanitization, gloving, And as I think one of our colleagues said, not misuse gloves. I've gone to places where I want to cry when a healthcare provider is using gloves to change patients and then goes to receive telephone calls with the same glove and goes back to change the patient. You know, that kind of stuff. You know, those are important things. Now, in terms of the other rights, the rights of quality of care, the right of patient-centered care, so that the needs, and Angie has very, very well vocalized this. Do we actually see this as somebody's sister, somebody's wife, somebody's mother, you know, so that it's not the patient with eclampsia or the patient with this and that, but she is Maria Torore, you know, that kind of stuff, so that the person, and we can learn from banks. They don't call you customer, they call you, and in fact, they will, if they are forgotten, they will very quickly, Professor so and so, we have not seen you for 2 weeks. Why can't we adopt those kind of stuff? Then, of course, in the era of COVID, we cannot forget about reorganizing the services, the administrative controls, and reorganizing the services so that, you know, people observe physical, I want to call it physical distance, so that the transmission, the nosocomial transmission of COVID is reduced to a minimum. And of course, other, you know, the comprehensivity of the services, I think, is a part of the rights that the woman deserves. I think those are some of the things. And of course, you know, just making sure that the services are strengthened. We are seeing evidence, say from Kisumu, where over the last 4 or 6 months, women are coming into the health facilities to die. You know, I want to stop. I almost want to cry at that point, but I will not cry. You know, so sensitivity of some of these indicators should help us to improve, to strengthen. If there's any sector in the health system that is sensitive to a weak healthcare system, is the maternal and the neonatal services, and it will come out very quickly. You know, the deaths that occur, the morbidity, and so on and so forth. I think that's what I can say with respect to the human rights. I want to mention a bit about goals of advocacy. You want to think about who are, you know, the players. I think professional societies have generally failed women. COGS, KMA, KPA, you know, Kenya Pediatric Association, they have a role to advocate. We are the biggest advocates for our patients, women, children, and that kind of stuff. So we need to advocate for quality reproductive health services. We need to advocate for increased financing, the Abuja Declaration, and things like that. I think those are some of the things that I would like to mention. I had notes, but I've ticked them off every time Otara opens his mouth. I tick off what I thought I was going to say. Then Odula comes, I tick off. Then Angie comes, I tick off. So I ticked them off so much that I don't think I have any left. But I would like really to thank my colleagues, Maria, for organizing this together with Elizabeth, and, you know, as KMA Reproductive Health Committee, we always pride ourselves as being that committee in front. If you see a committee in front of you and you have not seen the writing, know that it is Reproductive Health Committee. Thank you. In another 2 weeks, 2 or 3 weeks, we are going to make another presentation in sexual and reproductive health, and we will, you know, we'll expect you. In fact, I wanted to indicate that I was making the counts. I've seen up to 300 participants. That is something we should pat our backs for. We are very happy. In fact, this is one of the indications that digital technology is better. I wanted to debate digital technology. We would have had to travel, I don't know to where, but now we are doing it in the safety of our sitting rooms, and, you know, being given Gideri or Uganda or Nyoyo without any problem. Thank you very much, and Joy and everybody else. I'm very excited. Amos, Kali, and Angie, thanks for making us proud. Thank you.
Thank you so much, Professor Nyunya. Thank you, Dr. Joy Mugambi, our other panelists, for very timely comments. At this juncture, I want to thank our speakers again. The Q&A area, our speakers have been very kind, and during the meeting, they've been answering the questions as we go ahead. Many people have been asking whether this presentation shall be shared. Yes, they shall be shared. CPD shall be provided. There are many things we have learned from this CME. It was very broad. It was like 3 webinars in one, because we've learned about COVID-19 and maternal care. We have learned about respectful maternal care, which is a very big thing. And I think, Angie, maybe next time we shall just have a whole webinar where we shall discuss maternal rights. I've seen Sandra Murani as well from your team here, and we have met in another forum discussing maternal rights. So I think that's a very big deal. And yesterday there was also another webinar discussing disability and the challenges that people have faced either in the workplace, and even challenges that women face in terms of access to sexual and reproductive health services. So I think that's also another area, even as we go into advocacy, what are you able to do? I've seen some of the members commenting that they've never seen the charter. So Angela, today you have reached out to the doctors who have never seen the maternal rights charter, and I think maybe we need to sensitize more so that we become more aware of the fact that women know what they want. We always knew that they wanted better sanitation, but now they have told us that that is what quality is to them, and that is what we need to provide before we take them to Princess Zahara's pavilion. So without further ado, I'll just take a round of comment from each of the speakers. Then I will invite Dr. Simon Kigundu from our National Executive Committee to close the meeting. So we shall start with Dr. Otara to make just a 1-minute comment, and we follow up with Dr. Carol Dula. You're muted, Dr. Otara.
Almost.
Colleagues, and talking broadly about a subject that we are so passionate about, that is maternity care for our mothers. Even during difficult, I think we all appreciate we must take good care of them. They need the highest standard of care, and it's an opportunity. Every challenge presents an opportunity for us to lobby and get things done right in every other facility, be it the public hospital or the private hospitals. This is the time, I think, as policy and advocacy groups, we need to move and lobby the governments to ensure that they put in place preventive measures to protect our women as they come to our facilities, to ensure that there's respective care. I think that I'm really enlightened because the other presenters went out and really brought in other aspects of healthcare that are cool. Thank you so much.
Dr. Kali.
What an evening. I've really enjoyed myself. I learned a lot. For me personally, as a clinician, as a midwife, because I think I call myself a midwife. If you don't have any PR, you will not give your woman a good experience. Be kind, be kind, be kind, be communicative. That's why you have the knowledge, share the knowledge, be communicative, be kind. Before anything else, it is a person-to-person experience and should remember you for the rest of her life. The other things that come in, as Professor Nyunya, Dr. Otara talking about, is let's create environments that can allow us to achieve our best potential as to work. That's where we spend most of our days. And I think COVID has come as a blessing in disguise, because post-COVID, things will have to change. Take care of yourself, take care of your women with respect, like Angela is saying and emphasizing. Let us be kind to each other, and let's enjoy our work. We chose to do this work. Let's not take it for granted. Thank you very much.
Okay, before possibly we move on to the next panelist, Professor Nyunya, maybe you can, and Dr. Kali, maybe I can stick to Dr. Kali. There's a situation here. A mother for elective cesarean section due to 2 previous car term has flu-like symptoms. She's had a mask and staff are in their usual theater regalia. Advised on spinal anesthesia for possible risk but declines. What next? Dr. Carol or Dr. Otara?
Okay, thank you. That's a very, very good question. And it's a scenario that we're seeing daily. How did this clinician, how did this doctor explain to the mother the need for spinal? And I just finished talking. I said, it's a PR exercise. Take time. Tell her, this is what we need to go through. Write it down, explain to her the situations. She is not without a brain. She will understand. She will understand. She's nervous. She's scared. Was she admitted in time to just calm her down? Was she told, 2 previous car, utakufa, apana. Give her time, take time, come back, cool her down. If it means delaying the cesarean by an hour, so be it. Delay by an hour. Give her what is best for her and her baby. That's my take.
Thank you so much. Dr. Otara, do you have a comment, or I can move on to the other panelists? Dr. Otara does not have a comment. So, yes?
Comment. I think an important aspect to this, that client, most probably you'll have had contact with her much early. A decision like that will have been made very early. The counseling, they're not talking at, but with, using professional counseling skills that generally doctors are not good at so much, but it is becoming clear that communication, interpersonal communication, and inviting yourself into her world, empathizing with her, so that it is, it's a communication, and it doesn't have to be a one day. It is, over a period of weeks, months, so that by the time she's due for that elective surgery, you will have understood. Many times you even have to bring others, because difficult, I'm calling difficult in quotes, but there are circumstances where you need some expertise outside you to reach out to this client. Thank you.
Thank you so much. I am seeing Angela is almost doing a happy dance because her message is getting to the clinicians. And I think if all of us were to get this, I think maternity care would change and reproductive health services. Many people would.
Has allowed me to become a midwife also.
Okay. So we'll go ahead and ask Angela to make her 1 minute comment. Karibu, Angela.
Thank you so much. It's actually, it's been one of my most wonderful evenings. I've learned a lot, and I'm happy that we are all connecting and we're at the same place. And I really wish we all connected as the healthcare, the broader healthcare team, even in the maternity health. I think that is where there's another place that we need to all connect, because we are disjointed in the health, in maternity, in the labor ward. We are disjointed. Everyone is alone. Everyone is pulling. We are fighting, yet we are supposed to be working towards this woman that we are supposed to be giving the best care. I'll summarize by saying that pandemics don't call us to abandon respectful care. In any case, I think this COVID, there's already too much anxiety. So at this time is when we need to be more dignified and more respectful and more informative to the mothers that we are serving. I'll also say that we need to embrace innovation. We have embraced innovation, and we started by saying that we're already in a digital era. We should also embrace innovation in terms of how do we communicate to our mothers, even how do we do even telemedicine for ANC, post PNC, and every information that we need to get to our women. There's so much that we can do, including telemedicine, including breastfeeding and companions, even using technology during labor, like a cesarean. We can connect them to their families using technology because it's there. So I think we need to think innovative even in our practice, not just in the way we conduct our business outside the labor ward. I think there's another element that we need to embrace as healthcare team, which is self-care. We need to embrace the element of self-care. How do we get even these our mothers to embrace self-care? How do we package the information for them to be able to even take charge? Because if they did that and we did our bit, I think we'll get better maternal health outcomes than what we are doing now, because they have left everything to us, that because they don't know. So if we embrace self-care and incorporated it in our care, even during this era and beyond, I think we'll get much more and lesser use of our resources. And of course, I'll say that I've heeded your calls to everyone who was joining KMA. I'm already a KMA member via Elizabeth. Dr. Nunya, you can become a midwife. We can connect and do much more, especially around the Respect to Maternity Care Charter. And I think I had the same thing with KMPDU, that the charter is not known amongst doctors and specialists. So I think it's a new starting point to connect, even around self-care and other ways that we can actually connect and push at the dignified care. So I am happy to connect as with my team, with everyone else, and basically see how do we move this forward as a healthcare team, not just as segmented entities, because at the end of the day, it's about the mother, it's about the newborn. And all of us are working towards positive maternal health outcomes. And together, I believe we can go far. Thank you so much, and God bless you.
Thank you so much, Angela. I think Professor Nunya and Dr. Mugambi are the ones who have not made their comments. I will allow them to make their comments briefly before we move on to Dr. Kigondi.
Okay, I actually thought I was making my closing comments. Mine is really just to emphasize that we feel, passionate about women. Without women, we will not be here. And more importantly, for some of us, we would have no jobs. Yeah, we would have, we would not have no jobs. But more seriously, the health care of our women needs to be put in the front burner. It needs to be put in the front burner through, those 5 functions, not just healthcare, but through teaching and learning, through research, through management, and overall through leadership. If we do that, I tell you, we can't go wrong. And it's one of the most cost-effective investments. It's one of the most cost-effective investment. And COVID should be demystified. We should strategically routinize the care of women in this COVID era, so that those secondary impacts that Dr. Otara mentioned, we minimize them. We should not just be subject to what has been described as the tyranny of the agent. The agent makes us forget about essential maternal care, whether it is safe abortion, whether it is safe delivery, whether it is postnatal care, and so on and so forth. Thank you very much.
Dr. Joy?
Thank you very much. Thank you, Liz, for this opportunity to share. Mine is, as we close, I'm very passionate about community engagement. Working in rural Kenya, I've learned one thing: for maternal health to be successful, you've got to engage the community, from the CHWs, the households, to the CHWs, to the religious leaders, to the TBAs, and to also the husbands that are in those households. If you do engage them, your maternal child health will be very, very successful. And during this COVID time, to get these mothers to come to the facilities, engage community engagement, strengthen primary health care, and yes, rational use of PPE, and engage all the hierarchies of personal protection when working with COVID and these mothers within our maternities. Thank you.
Thank you so much. It's been a very, very amazing evening. To give a vote of thanks, I would like to appreciate all our speakers, and I've appreciated you so much today. Also, I also want to appreciate our participants who joined in today. We do this because of you, and we are happy that you shall share these messages even to other healthcare workers, and even that we shall improve patient care going ahead. I want to also thank my co-presenter, Maria, who's our reproductive health project associate, who's been helping Professor Nunya achieve the objectives of the Reproductive Health Committee. Again, I want to thank the Reproductive Health Committee, which is headed by Professor Nunya, for this activity. And we are hoping that we shall have way more presentations around the sexual and reproductive health services. And more so, we shall be incorporating other associations. Angela has mentioned the issue of partnerships, and we are hoping that going ahead, most of the CMEs shall be held in partnerships with the nurses, in partnership with the clinical officers, so that we are all, even as we improve maternal care, we are all moving in the same direction. Thank you again to the whole of KMA National Executive Committee for giving us these opportunities, for always making sure that the KMA activities go on. I will invite our Secretary General to basically close the meeting and give the way forward. Dr. Kigondo, please, if you're around. Okay.
A young person, yeah.
Okay, Dr. Kigondo, I think possibly has left a bit. So I will ask the convener of the Reproductive Health Committee on behalf of.
I'm here. Wait. Nikki.
You are here. Are you in Muranga?
I want to thank Dr. Otara and Dr. Kali Odula. Those are my seniors for the presentation. And I think I've put on the chart a write-up I had done on COVID and maternity. So people can read it up. And we want them to join Kenya Medical Association. It's advocating for maternal health. And we want to thank you all for this presentation. Thank you.
Thank you so much. On your screen there, you will see that we are having a presentation tomorrow on COVID-19 county experience sharing, what we are calling the KMA Division Pecha Kucha Nights. We started last week with the Nakuru team, with Dr. Otara, Dr. Joy Mugambi and team, and we had an amazing time. Tomorrow we are going to Coast. After Nairobi, it is the one with the highest number of COVID-19 cases, and we shall be hearing from two very amazing doctors from there, one of whom is a leader of KMA, and they shall be telling us what has been their experiences down at the coast with dealing with COVID-19. So even to our reproductive health partners here, possibly tomorrow you can join in and ask how maternity is ongoing in Mombasa in view of COVID-19. Thank you so much and have a good night.
Thank you. Thank you very much for having us. Thank you. Bye.